students, welcome to the session. Now in the series of this arthritis, this session is going to be one of the, again, a very important session. The last one was about the osteoarthrosis, which you see a lot typically in orthopedics, but this one, that is the rheumatoid disorder, is also seen in the other branches, let's say, medicine also you see. The first few parts of this particular rheumatoid is similar what we have discussed in osteoarthritis. So I'll just go through each slide, but I will not go into the detailed description if you want to learn, because this I have kept it so that whenever you come to this arthritis session, especially the peripheral joint, you must remember these facts. But we have discussed these facts in septic arthritis partly and again in osteoarthritis. So if you really want to go in detail of that, you can always go through those sessions and understand the basics of the asynovial joint. So as we have discussed, arthritis is basically inflammation of a joint, but pathologically when we say arthritis means destruction of a joint. So this is a normal joint looks like, but a arthritic joint is a joint where there is a destruction of the cartilage. You can see this is a destruction of the cartilage. And this is again a normal joint. We have discussed again and again the relevant anatomy of the synovial joint. So I'll just go through each slide. You can pause it here. You can just revise these contents which have been discussed in the past and then move on to the typical rheumatoid. So all these anatomy, physiology, function and various aspects of the hyaline cartilage you must know at least couple of times before you move on to the rheumatoid. So these I am just stopping here so that you can again and again see them, revise them and then move on. This is the same classification which we have discussed when we started with osteoarthritis. So we are going to discuss typically the rheumatoid arthritis in this session, but the ones which are highlighted in red will also be discussed in other sessions. So I'm starting with a typical history. A 30-year-old female presented in orthopedy with bilateral wrist and hand pain, and stiffness 6 months. Pain was more in mornings, associated with stiffness, and improved with work. So she would to say, when I get up in morning, my hands are quite stiff. And often happens that you have to ask the patient his history, they won't come up with this information. Because you have to differentiate, is it a mechanical pain or is it a rest pain or an inflammatory pain? She started also noticing some deformities in his fingers in last few months. There was also a mild tingling which she felt in her right hand in the night. So she said, when I sleep in the night, I often get up and there's a lot of tingling in my right hand. When I shake my hands a couple of times, the tingling is much less. Then she said, in last a month, I suddenly noticed that there is a progressive deformity in my leg, right leg, which shows a outward deformity. In our language, we call it as a genu valgum. And she also told that her mother and actually the sister also had the similar problem starting in a quite a young age. Mother never took any treatment, sister is on treatment. What do you think we are dealing with? I'm sure that most of you have heard about it and most of you are not confused when I put up these, especially these two pictures, that this is nothing else but rheumatoid, typical rheumatoid presentation, which is a chronic, inflammatory, autoimmune, multi-system disorder. So don't get confused that it's merely an arthritis. It is actually a multi-system disorder of young adults involving connective tissue, chiefly synovium, characterized by chronic symmetric erosive polyarthritis. Chronic symmetric erosive means it's for a long time, it's erosive and there's a symmetry in this. Synovium is not only in the joints, but it's also around the tendon. That's why you also get a lot of tendon ruptures. So synovium covers both joints and tendons, hence both are affected in rheumatoid arthritis. This disorder affects typically women who are young, about 20 to 40, sometimes up to 50. Women to men ratio is about 4:1, and there is a familial history. It's more common on the maternal side. There are some etiological factors. So one of the most important hereditary or genetic reason is presence of the HLA-DR4 gene. There are some unknown antigens which are probably the degradation products of bacteria or some viruses like Epstein-Barr, rubella, mycoplasma or bacterial cell product, and there is a involvement of cell-mediated immunity antigen-antibody complex. We'll just try to see the pathogenesis. I'm sure that you have read the same thing in pathology. We would have also discussed a bit about in the medicine, not usually asked in exam to draw, at least in orthopedics, but it's good to know that how it happens. So what happens that there are antigens which are presented, these are bacterial cell products or various antigens, it are presented to the macrophages in synovial membrane or connective tissue, and with the genetic predisposition of HLA-DR4 and DR1, these macrophages presents processed antigen to helper T cells. Helper T cells further stimulate the B lymphocytes and which start producing the antibody secreting plasma cells, and these antibodies like this IgM and IgG complexes, they finally get deposited in the synovium of various joints and tendons. It also causes synovial angiogenesis, and this finally results in with immune mediated inflammation, synovial hypertrophy, pannus formation and cartilage destruction, something lump sum similar what happened in the septic arthritis. T helper cells also stimulate the B lymphocyte which also release the cytokine. So T cells also release cytokine which also cause the inflammation, synovial hypertrophy. So this is a very complex factor where cytokines, antigen-antibody complex, they cause this. So if you want to remember one line, you can always say it is basically the complex deposition in the synovium along with the cytokines which cause the inflammation, hypertrophy, pannus formation and cartilage destruction. But this is the process which happens before. Again, like what we saw in the septic arthritis, there are three stages: synovitis, arthritis and stage of deformity. So in the stage of synovitis, these antigen antibody complexes, they are deposited in the synovium, leads to a lot of synovial hypertrophy, inflammation and the effusion. But here there will be no purulent inflammation. It is usually the serous or maybe sometimes turbid looking inflammation. But there is always a pannus formation over the cartilage. Something like this, there is a pannus formation. Once there is a pannus, along with lot of enzymes which are released due to the cell death, pannus is going to choke the cartilage and altered synovial fluid quality. You see, in the septic arthritis, it was the pus, but here it is all altered. It's all turbid. It has got a lot of inflammatory factors. Now, it is not the original synovial fluid which is designed to nourish the cartilage. You have a pannus sitting, you've got a lot of inflammatory factors, collagenases, a lot of lysosomal enzymes, metalloproteinases, cytokines. They all, along with the lesser movement of the joint, that cause the cartilage destruction, which causes the arthritis. So at the end, you can say enzymes destroy, pannus chokes and altered synovial fluid cannot nourish. This causes cartilage destruction and followed by arthritis. This is very simple chart to remember. If you can't remember this one, at least remember this one. And lastly, with the cartilage destroyed, bone end starts getting exposed. It starts resulting in fibrous ankylosis. There's a lot of muscle spasm, capsule contracture, tendon rupture, ligament gets stretched over the years of recurrent effusions and remissions and exacerbation. Finally, it causes a deformity, subluxation and fibrous ankylosis. This is the stage 3. So synovitis, arthritis and stage of deformity bar fibrous ankylosis. Bony ankylosis in septic arthritis. As I said, it's a disorder of connective tissues. It's a multi-system disorder. It is not only affecting the joint and synovium and the cartilage or the tendons, it is also affecting almost all organs of the body. It causes vasculitis, lymphadenopathy, splenomegaly, myopathy. It affects the nerves, it affects the various organs like heart, lung, kidney, GIT and brain. So nothing is left. We're moving on to the clinical features. Articular. What are the joint features? This is a very important topic. Again, I'm emphasizing, go through this topic in detail. So classically, it is a disease of appendicular skeleton. Means it involves the peripheral joint, not the spine or sacroiliac, except the C1, C2 junction. SI joints and spine are not typically involved in the rheumatoid arthritis, where this is the area actually which gets involved in the seronegative spondylorthopathy. So seropositive remains outside, seropositive is periphery, seronegative is axial. Symmetric arthritis of the small joints of hand. So typically they come to you with a symmetric arthritis of both the hand and the foot. There will be morning stiffness for more than an hour, and deformities could be seen in the hand and foot. I'm sure that all of you know this ARA criteria, okay, which was by the American Rheumatology Association given in 1987, where there are 5 clinical criteria, 1 serological criteria and 1 radiological criteria. And you need to have at least 4 out of 7 criteria, 1 to 4 must be there. Means there must be morning stiffness, arthritis of at least 3 or more joints, wrist and hand must be involved. There it should be symmetric. Rheumatoid nodules may not be, RA factor, and typical X-ray changes of the wrist and hand. Euler criteria are also there, which involves the joint distribution, symptom duration, serology, and acute phase reactant. No one asks you in the Viva, nor you can write it in exam because it's a bit detailed, but remember there is a Euler criteria for rheumatoid arthritis. Take your time, go through this slide, you realize that there are 4 features: joint, symptoms, serology, and acute phase reactant. Each are given points. This is one slide. Hold your breath, stay here and read it again and again and again, because they are usually asked sometimes as a short note. Enumerate the clinical features of rheumatoid arthritis in hand. What are the hand features of rheumatoid arthritis? So swan neck deformity. You can see here the picture. So here there is a PIP hyperextension, proximal interphalangeal joint hyperextension, and DIP flexion. This is swan neck, like a neck of a swan, something like this. Something like that. That's known as a swan neck deformity. So this is in hyperextension, this is in flexion. Buttonia deformity. So that's the buttonia deformity. It is just reverse of the swan neck. Ulnar deviation at the MCP joint. So if you see these fingers, this is the ulnar side, this is the radial side. All the fingers, they start shifting, drifting towards the because of the tendon ruptures and the ligament laxities. They drift towards the ulnar side. Metacarpophalangeal joint subluxation. So here, if you see carefully, in my hand, if you see the metacarpal and the phalanx are almost in the same line. Here, you see it's in the same line. Whereas if you see in this picture, the metacarpals are here, where the phalanx are, actually the phalanx should have been here. It is subluxed downwards. So finger, MCP, then Z deformity of the thumb. How does it look like? You see, this is how the Z deformity of the thumb look like. See this? This is the Z deformity of the thumb. Then radial deviation of the wrist. So the wrist deviates laterally, radially, fingers deviate ulnarwards. Remember this. Dorsal subluxation of the ulna. The ulna subluxates dorsally. And capitalness syndrome and trigger finger and trigger thumb. At least you should remember this much. Because this is, you may not, capitalness syndrome is basically the DRUJ subluxation, stretching of extensor tendons, and volar subluxation of the, volar subluxation means the carpal goes down. That is capitalness syndrome, usually asked as just an MCQ. There are 3 syndromes: Manner-Felt, Vaughan-Jackson. Again asked as a part of MCQ. Manner-Felt syndrome is seen in, or what is the typical of Manner-Felt syndrome, in which there is a FPL rupture in carpal tunnel syndrome. Vaughan-Jackson, here you can see actually rupture of hand digital extensor tendons, hand digital extensor from ulnar to radial side. So it starts from here and comes to this side. And arthritis mutilans. The hand is very grossly deformed. It is also seen in psoriatic arthropathy. Carpal tunnel syndrome. So you remember the case history? The case history lady said that when I sleep in the night, I get a lot of tingling and numbness in my hand on the right side. Carpal tunnel syndrome is quite common in rheumatoid arthritis. So when we'll discuss carpal tunnel sometime, we will have this. So from the hand, we go to the foot. Again, these are various deformities. The most common is hallux valgus, You may also find varus, plantar subluxation of metatarsal heads, clotto, bunion, flat foot, lateral deviation of toes. You can see these toes could be lateral deviated, equinus, valgus, and so on and so forth. You can just go through that. In exam, you can remember at least one or two. Just write hand. They will always ask feet and other areas. You can just remember and write at least one or two. This is important. Never forget this. Osteoarthritis, genu varum, rheumatoid arthritis, genu valgum. And why genu varum in osteoarthritis? Because as we walk, the weight bearing axis is more towards medial. Since it is a wear and tear related disorder, there is more degeneration which happens in the medial compartment. Hence, you start getting the varus deformity. Rheumatoid arthritis is a symmetric disorder. It happens everywhere. It happens everywhere. And that is the anatomical axis. What we are talking about is the anatomical axis where there is a weight bearing axis, where the weight passes through slightly more to the medial joint. Whereas in rheumatoid arthritis, since the anatomical axis, the femoral head, normally this is how our body axis is designed in this fashion. So this mechanical axis where this is the femoral axis, this is the tibial axis, it is always aligned in valgus. And since there is a symmetric damage in both compartments, it just goes slightly more laterally. So that's why you get more of a genu valgum rather than the genu varum. Okay, so please remember this. Windswept deformity. In one knee, you may get a varus. In one knee, you may get a valgus. So it's like a cartoon character which is trying to hold a ground against a very strong blowing wind. So you may see a cartoon character which, kind of holds the ground against a very, very strongly blowing wind. That's known as a wind-swept deformity. Then genu varum and flexion deformity can also happen. This is again, you can see a genu valgum deformity. So hand, foot, knee, cervical spine. It can, all the joints are involved. You can have the arthritis in the shoulder, in the elbow, in the hip joint, and so on and so forth. But the typically involved are hand, you can also say the knee joint, foot and ankle area, and then the C-spine. What can happen to the C-spine? Atlantoaxial subluxation. This area is known as ADI, atlanto-dense interval. This is always increased. ADI is increased. Basilar invagination in subaxial subluxation. The medical importance of this is somebody has got a chronic neck pain and he has got rheumatoid arthritis. One of the treatment modalities for the neck pain is we send the patient for cervical traction in physiotherapy. Do not do that because that area is weak and unstable. If you do that, there is a chance that it will completely subluxate and it can actually impinge upon floor of the fourth ventricle, causing instant death. So the people who have neck pain with rheumatoid arthritis must rule out atlantoaxial instability. Those were the articular features of various important joints. And now we go to the extra-articular. So generally they can have fever, weight loss, loss of appetite. Bones can have generalized osteoporosis. This is very important. Look at this subcutaneous nodule. We call it a rheumatoid nodule. They are the single most important extra-articular feature of rheumatoid arthritis seen in about 25% cases. They are commonly over the extensor aspect of the forearm, sometimes over the pleura also you can see, and they always indicate severity of disease. So somebody who is having a rheumatoid nodule, it indicates that the disease is quite severe and the titers could be high. RA factor titer will be usually high in the patients who have rheumatoid nodule. This is a list. You have read about it in medicine also. I would hold on for a few places. You can go through this list. There's no place which is not affected. But Felty syndrome is often asked in exam. Kaplan syndrome. And you must not forget the keratoconjunctivitis sicca. And in the hand, entrapment neuropathy, especially the carpal tunnel syndrome, or in the foot, we call it as tarsal tunnel syndrome can happen. Then not to forget anemia of chronic disease, very, very important. So the people who are having any kind of chronic inflammatory disorder can have anemia of chronic disease, which itself you would have read in medicine. So from the etiology, to understand that it's relatively a genetic process, More common in women, familial, sometimes inheritance. Pathogenesis, where it involves some kind of an antigen which is processed by the bacteria, presented to T cell and then B cell, and then a lot of antigen antibody complexes are formed which are deposited in synovium. The joint undergoes 3 stages: synovitis, arthritis, and deformity, with lot of features in the hand, partly in the foot, okay, C-spine, and all other joints are also involved. ARA criteria must be remembered because they often ask in exam, and never to forget the rheumatoid nodules which you have to see here. If they are there, it usually indicates the high titer of disease. How do we confirm the diagnosis? Blood investigation, very simple. Plain X-ray of the joint. These are the 2 things which we do routinely. We don't do routinely because 99% of the time you will be able to confirm the disease process here itself. Sometimes we do this. Synovial biopsy. Why synovial fluid analysis? No, I'm not writing here, but you have to make a note of it. A patient who is a known case of rheumatoid arthritis, who's on treatment, suddenly one day presents to you with a right knee swelling. He had rheumatoid arthritis and he also had the features in the knee. But one day it is swollen, it is warm, it is angry. That can be feature of inflammation also. One of the treatment of rheumatoid arthritis is to give steroid, either local or you give systemic. Can I give local in the knee? Never. Remember a dictum: acute exacerbation, acute monoarticular exacerbation of a joint in a patient who is a known case of rheumatoid arthritis should be investigated for septic arthritis unless proved otherwise. So I will repeat: acute monoarticular exacerbation of a joint in a patient who is a known case of rheumatoid arthritis, should be investigated for septic arthritis unless proved otherwise. And how do I confirm that there is septic arthritis? You saw the gold standard investigation is joint aspiration. So that's where the synovial fluid analysis comes. Routinely we don't send. Small joints, want to see the synovitis, you can do the ultrasound. And if you're confused, what is it? Blood tests are not really, in favor, then you can do the biopsy. So blood investigations, CBP, the hemoglobin is usually low because of anemia of chronic disease. And you must know that these patients, iron subscriptions are not given unless there is a low iron also. They require the blood transfusion or just the control of disease. ESR and CRP are raised. RA factor is usually positive, but only in about 60 to 70% cases. This is usually a Viva question. What is RA factor? You can read this. I'm sure that they would have taught it in many places. It is an IgM antibody against the Fc fragment of IgG antibody. It is very sensitive but not specific because it is also present in 5% healthy population, SLE, Sjogren's, syphilis, TB, the Hansen's, and so on and so forth. But there is one investigation which is very specific, that is known as anti-CCP antibody. That is anti-cyclic citrullinated peptide antibody. It is very specific. Almost 80 to 90% of the cases you will find this. If RA factor is very strongly positive, a lot of people don't do anti-CCP. If RA factor is negative, then we always do the anti-CCP. Plain X-ray, it's an arthritis. So one thing is for sure that you will find the joint space reduction. Okay. But since it is a symmetric arthritis, so you'll find more symmetric joint space reduction as compared to osteoarthritis, where you find more of the medial compartment OA. Look at this. This is medial compartment. And here, this is space and this is space, or this is space and this is space are equally getting eroded. That's quite typical of rheumatoid, or for that matter, any inflammatory arthritis. That inflammation happens across the joint. So why should it happen in one place? Why should it get only medial, only lateral? That usually does not happen. It is usually more symmetric. One also gets periarticular osteopenia, and osteophytes are not common in inflammatory arthropathy, any inflammatory arthropathy. These 3 factors help you in figuring out, am I dealing with a osteoarthritis or is it a inflammatory arthritis? Here again in the hand you can see this is the normal hand X-ray. Look at this normal beautiful hand X-ray. Normal wrist joint space intercarpal spaces, MCP spaces, IP spaces, and look at this. These spaces are reduced. And look at the density of the X-ray. This X-ray looks porotic, whereas this X-ray looks normal. Okay. And here you see, you can't see a carpal because everything is all merged. All the intercarpal spaces are gone. It's completely arthritic. Okay. Look at from distance, you see, you know that this looks more penic, whereas this looks much more normal. It's very deformed hand. You saw one of the picture, the same X-ray, very, very deformed hand. Rheumatoid versus OA. X-ray features. This is very often asked in Viva short note sometime. So osteoarthritis is asymmetric, Varam deformity, and this is for the knee. I have written for the knee. Okay, so this is typically for the knee. Varam deformity, prominent osteophyte, and you will not find a periarticular osteopenia. Whereas rheumatoid will be symmetric, valgum, no or very minimal osteophyte, and periarticular osteopenia almost always. So what are the goals? So we have investigated, confirmed. Now we have to treat. Reduce and stop pain and inflammation. If they have terrible pain, inflammation, reduce it and stop it. Preserve and improve the mobility of the joint, and lastly, preserve and treat the deformities. And how do we do? See, you will now find this chart everywhere because I follow this even in my practice. General, physiotherapy, orthotics, medical, and surgical. So general is you have to give them nutritional support, treat their anemia. If it is anemia of chronic disease, they may require more of a blood transfusion rather than giving them iron supplement. That's why where you have to do the ferritin studies and all. But most important is counseling regarding the disease process. They have to understand that largely they cannot eradicate. It cannot be eradicated. It can be only controlled. So the treatment is usually lifelong. They should not leave the treatment and disappear because once they get control, they say, oh, I'm fine. So then they leave the treatment. If you leave the treatment, they come back after 1 year with more severe deformities. So counseling about the disease process is extremely important. Same physiotherapy, mobilize the joints, muscle strengthening exercises, splint it to prevent the deformities. And pain relieving physio in form of moist heat, TENS and shorted diathermy, ultrasound, etc. Go to the medical, which is the mainstay. Medical treatment is mainstay where there are in general 5 things. You can give them analgesics. Typically we give NSAIDs because you need to control the inflammation also. Disease modifying agent, which are by and large mainstay, gold standard of the medical part. Then steroids, which can be given systemic or intra-articular. Then biological agents, which could be either TNF antagonist or interleukin-1 antagonist. So NSAIDs help in reducing the pain and inflammation, but they don't change the disease process. The disease process remains the same. But they have to be given along the disease modifying agents because disease modifying agents are going to take at least 6 weeks, 8 weeks, 3 months to act in full. And till then, patients has to be given some pain relief. Disease modifying agents have they have been able to help the disease getting controlled, and it slows the progression. It helps in preventing the consequences, especially the deformity. And it's very useful in the stage of synovitis where there is still no arthritis. And it's usually given for long term. Once you start, it's not usually stopped. These are falling drugs. Traditionally, 2 of them are used most commonly, methotrexate, which is the drug of choice, and hydroxychloroquine. Methotrexate is usually given along with the folic acid to avoid the megaloblastic anemia. It is predominantly hepatotoxic. So once you put them on, you have to monitor every 2nd month or 3rd month the liver function test. Hydroxychloroquine, before you start, you have to get the retinal checkup done. Okay, because it can cause a lot of retinal changes. If the patient has got liver toxicity, you can always shift him to the leflunomide. Sulfasalazine, penicillamine are also there. They are also used. Gold salts are also used, but not so frequent, at least in today's era. Steroids, yeah, it is given. Systemic to start with when you have to control the extreme of inflammation and pain in the disease, and then gradually it is tapered. As they get exacerbations or 1 or 2 joint, as long as you have ruled out septic arthritis, you can give local steroid injections also. Some people or sometime in some patient, you have to give it for a very low dose for a long term. But always remember the orthopedic side effect of these steroids. I'm sure that you know the steroid side effects which happens in rest of the system also. But orthopedic side effects could be generalized osteoporosis and avian, two very, very important complications. Generalized osteopenia and avascular necrosis of the hip. So they will frame the MCQ on these. Patient who had a rheumatoid arthritis, who his hip was fine when he first time came, but he was put on these disease drugs, including steroid. After 3 months, patient came back with some limp. He had some pain in the hip. Examination showed restricted abduction, external, internal rotation. What is the likely cause? Avian. Because steroids can cause avian as short, given for even for 6 to 8 weeks, they can cause avian. Biological agents, TNF-alpha antagonist, that is etanercept, infliximab, adalimumab, or interleukin-1 anakinra. These things are also used, especially when the disease-modifying agents and the analgesics and the steroids are not able to control. But what is important is, it is usually given in combination, not in isolation, and given only when the primary treatment modalities fail. They have high cost and very considerable side effects, something like infection, demyelinating disease, and there are some questions about risk of malignancy. On to the fourth one, that is the surgery. This is a list of the diseases. You need not to go into the nitty-gritty of each disease, each joints, but you see, we do the surgery for the structure involved. So if there is a tendon rupture, we do the tendon repair, tendon transfer. If there is a nerve involved, you can do the nerve release surgery. If there is a capsular contracture, capsular releases. In the joint, we do the synovectomy, arthrodesis, replacement, resection arthroplasty, or even an osteotomy. So these are choice of surgeries. You just need to list in exam. They are not very typical and particular about what you do. But let's say knee. Knee is very, very frequently involved. So they may ask you, in a 50-year-old woman who's got the rheumatoid arthritis, okay, she's got severe deformity, what's your treatment of choice? TKR, that is the total hip, total knee, or in the hip, total hip. So this is one video I will show you, which is about the synovectomy, which is similar what we saw in the septic arthritis also. So because we need to remove all this synovium which is everywhere, which is inflamed, angry, causing pannus. So this is the right knee joint with inflamed synovitis. With the help of saline infusion and inflation of the joint, we remove the synovium all over the joint. This is how we remove. Now we go to the suprapatellar pouch again and take a biopsy. When we are in the joint, we always take biopsy so that we are 100% sure anyway that we are not missing anything or if it's something else. So biopsy, this is how the biopsy is taken. Let's say if it is a tuberculosis, you can take the biopsy in the same fashion. And then this is how, it's like a vacuum suction device. It cuts and sucks the entire angry inflamed synovium. It also removes the pannus. You are doing a saline wash, so it also removes all the inflammatory factors for the time being from the joint. Go to every nook and corner of the joint, remove. And you give a lot of time for this joint, because once you remove the synovitis and pannus, you have given this joint at least 4 to 5 years before, if at all, it has to undergo any kind of arthritic change. This is the undersurface of patella cartilage which was damaged. We are just shaving it off and making it a bit more smooth so that her squatting and sitting cross-leg becomes a bit more painless. This is a joint which is almost, the synovectomy is done. The extreme part of the suprapatellar pouch is left. We are again removing it. So this is how the synovectomy is done. Rest of the surgeries are not really important for you. This is one slide again in nutshell. So general, counsel the process, nutritional support, anemia correction, physiotherapy, muscle strengthening exercises, joint mobilization, splint the joint to correct or prevent the deformity. The disease modifying agents are the drug of choice. You can also use intra-articular steroid and systemic steroids and biological agents only when the primary medical modalities fail. These are various surgical options which we use in rheumatoid arthritis. If it is a young patient with a strong positive family history, it's a poor prognostic sign, or it is a very high titer of the RA factor and along with the anti-CCP antibody. Or if the patient presents with a very early deformities or erosive arthritis, or there's a lot of extra-articular features. So in summary, rheumatoid arthritis is a symmetric inflammatory disorder of small and large appendicular joints. Women are more affected, and it is usually has a genetic and familial connection. There are 3 pathological stages, if you don't forget: synovitis, arthritis, and the deformity, which is not the case in osteoarthritis. Please remember, never in exam write those 3 stages. They do not happen in osteoarthritis. It is not a disorder of synovitis, arthritis, or deformity. Okay, this is typically described for inflammatory disorder, whereas osteoarthritis is a non-inflammatory arthrosis. RA factor, anti-CCP, and X-rays are usually diagnostic. Never forget the varum and valgum difference. Disease modifying agents are the medical management of choice, and surgical treatment is according to the stage what you got and the structure what is involved. So hope this session was very fruitful and you understood about the rheumatoid arthritis. But the differential diagnosis is psoriatic arthropathy, fewer joints involved, DIP, preferably the disease, the distal interphalangeal joint, and you'll find a lot of skin lesion of psoriasis which are unmissable. There is something which is very close to rheumatoid, and that is the SLE. In SLE, small joints of hand or foot are involved, but remember, it is non-deforming, non-erosive. Non-deforming, non-erosive, but there is a small joints of hand and foot involved, and you may find the skin rashes. But also in those patients, ANA and double-stranded DNA is positive, dsDNA is positive. Gout is very rarely polyarticular. High uric acid and tophi will help you in differentiating, and osteoarthritis we have discussed in detail how do you differentiate. There's another arthritis which is Jacquard's arthropathy, which is non-erosive arthropathy of the joint similar to RA due to repeated bouts of arthritis. Here you can see there's a deformity. It's an ulnar deviation of the fingers. You can see this. It's observed in SLE due to the capsular contracture. So there is an ulnar deviation, but the X-rays are looking normal. So it's a non-erosive deforming arthropathy. I'll just repeat again. So usually it is non-erosive and usually non-deforming, but sometimes you may find some deformation due to the capsular contracture, and that's known as a Jacquard's arthropathy. Complications are, it causes a lot of work disability, increased chance of joint replacement, infections, interstitial lung disease, Felty's syndrome, coronary artery disease, carpal tunnel syndrome, methotrexate-induced liver toxicity, and your biological agent-induced infection and malignancy. So with this, we summarize and finish our entire session on rheumatoid arthritis, which is a very, very important inflammatory arthropathy, seropositive. I hope this was a very fruitful session and you could take away a lot of good learning points from this. Thank you so much.